Hi Dylan, hi Ashwini, hi Rohit.
Hello.
Hi. Looks like the Adelaide team is here.
Hi Dylan.
Hey, Matty, how you going? Congratulations.
Good.
Last weekend done. Breath of freedom.
Well, a little bit of freedom, but
We'll drag you back.
get me back as many times.
Hello.
Hi Rohit, I can't see you, but I can hear you. I think we'll wait for about 5 minutes. So we get probably a few more people. Dylan, I was just asking Caitlin to see whether people are getting the emails, but anyway, I think she's on to that.
Thanks for that.
Caitlin, can you hear me?
Yes.
How many have registered for tonight?
I'll check. 18, and we've got about, say, 8. So 10 more people will join.
Okay, so anyway, we'll wait for another few more minutes and should get going. So Dylan, anyway, while we're waiting, did Caitlin recently send an email out asking if everybody in the transplant section was getting the emails? Did you respond to that?
I haven't got that email. I just wonder if I'm not currently included in the mailing list.
Okay, you heard that, Caitlin?
Yes, I did. I'll make sure that he's included.
Oh, thank you very much, Caitlin.
No problems. Sorry, Dylan, when did you get your fellowship, just out of curiosity?
Yesterday or today.
That's probably why you're not included. Sorry.
Yep.
Okay.
Congratulations, Dylan.
Thanks.
Yeah, sorry. That's why, but no worries. You will be now. That's fine.
Hi, Ashwini. Ashwini, can you hear me? Are you still there?
Yes, I am. How are you?
Any experience? Have you seen these nutcrackers before?
No, not at all. Actually, in the last couple of years. No.
Okay. Yeah.
We've had some where they're like, interesting things like renal artery stenosis and stuff, but no, not for Nutcracker.
Yeah. It's not very common. In fact, I think this is probably the only successful one we have done actually, and this is the only one I've been involved with. I think there have been a couple in the past, but that's before my time. I don't think there was any. I mean, there are a lot of anecdotal reports, but nothing wherein patient that actually had great improvement in their condition.
Mm. It'd be nice to see and hear what other people have to say.
I'm sure the urology crowd would have some experience with this. Ashwini, Rohit is the Dylan and Rohit have joined today,
Yes.
and Rohit is a urologist and Dylan is a general surgeon. Rohit used to work with me back in St. John's in Bangalore.
Oh, nice.
Mati finished yesterday, but kind enough to do the presentation today.
Mati survived the whole year, or was it just 6 months?
Oh, Mati, how long you were with us?
2 years.
Wow.
24 months.
Okay.
He's
I'll
a
still be
pillar.
around in the background though.
Still, that's pretty much you're like in the thick of it. So that's impressive. 2 years.
Yeah, I know it was.
Hi, Rohit and Dylan. We'll see you. I'll see you next month.
Yeah. Okay, I think we will get started, Mati. I think we waited 6 minutes. So anyway, looks, I think the others probably will join. So anyway, good evening and thanks for logging in today. And hopefully as the meeting progresses, we'll have more people joining us. So let me start by acknowledging this land that we meet on today is the traditional lands of the Ghana people, and that we respect their spiritual relationship with their country. We also acknowledge the Ghana people as the custodians of the Great Adelaide region. We pay our respects to their leaders, past, present, and emerging. So since the webinar started a few years ago, Adelaide team always kickstarts the year in the webinar series. And again, it's that time of the year when always we have the change of registrars and fellows. So anyway, since it's only the Adelaide team which is logged in so far, we know who is coming in and who is leaving. So thanks, Mati, for agreeing to present at today's meeting. Now, see, the whole idea of this webinar has been, there is it helps in the sharing of knowledge and sort of cross-pollination of ideas and experiences around, between the different units. And that's why we set up this webinar series, and it becomes like an informal way of discussing ideas and share people's experiences. So with that, I have a couple of slides. So this webinar, as I said, is the first webinar, and it'll be a 1 hour duration. And the problem with this particular issue of Nutcracker is the whole issue of diagnosing the problem and subsequently managing this problem. And usually what we have done in this particular patient is an auto transplant. Our experience with this is very limited. In fact, it is N equals 1 in the current era. But in the previous era, where other surgeons have had some experience, but again, they're all anecdotal experiences, and from what I understand, it's sort of a given up procedure in this unit. But then with this particular patient, it seems to have rekindled a lot of interest. We do auto transplants for other benign conditions like ureteric strictures, recurrent ureteric strictures, which we get referred from the urologist, and for other benign conditions like, say, angiomyelodysplasia and so on, and angiomyolipomas and all that, which we do auto transplants for. So with that, I think I'm happy for Mati to kickstart, and we'll follow with questions at the end. Mati, I'll stop sharing from my side.
Yeah.
Yeah, go ahead, Mati.
Yeah, thank you, Dr. Santosh, for the introduction. Is my slide visible?
Yes, Mati.
All right. Well, thank you. Thank you for giving me the opportunity to discuss this interesting case and interesting topic on Nutcracker syndrome. So the term Nutcracker itself was coined initially by Grant back in 1937, where he noted that the renal vein, when it was lying between the aorta and the superior mesenteric artery, resembled a nut between the jaws of a nutcracker. This is what we know commonly as the Nutcracker phenomenon. Now, when this is associated with signs and symptoms or clinical symptoms, this becomes what we call the Nutcracker syndrome. And this occurs usually when that angle between the aorta and the SMA is less than 41 degrees. Normally, it's supposed to be about 90 degrees. Now, Nutcracker syndrome can present at any age. However, it commonly peaks between the second and third decades. And from literature, it's noted to occur more commonly in females than males. One of the postulated etiologies is that during puberty, there's a rapid increase in height as well as development of the vertebral bodies. And this actually results in the narrowing of that angle between the aorta and the SMA. Now, the commonly described syndrome is the anterior one. However, there is another variant that is also known as a posterior Nutcracker syndrome. This is a rare syndrome, but this occurs when there's a retroaortic left renal vein, and this can become compressed between the aorta and the vertebral body. And this actually presents sort of in a similar fashion. So you can imagine if the anterior one is difficult to diagnose, the posterior one would even be more difficult. In terms of its presentation, it's very variable and usually presents in atypical ways. But the commonly described symptom is abdominal pain. And this pain can also be in the radiating the flank or originating in the left flank. Hematuria is one of the commonly reported symptoms. And some patients also report pain within the testicles or may not notice the development of varicocele in these areas. But its presentation is very variable, which makes it a very big challenge in terms of diagnosing and managing, because it can present in a very variable, varied way. Now, moving on to our case, this is a case that was managed now almost two and a half years ago. And it's a patient who was 25 years old, a male patient who initially presented to his GP with just worsening upper abdominal pain, as well as nausea. Now, this pain, he reported that this pain had been present for most of his adult life, but was sort of worsening in the last year. It was radiating to the back and to the left flank and also to his left testicle. Because of this, he had actually stopped working for about a year. He was not having much sleep at all from this. He had been trying to manage this by himself and had been self-medicating with Panadol Forte, taking up to about 4 to 6 tablets daily. He was also supplementing this with marijuana, which he was taking almost daily. However, because of the ever-increasing quantities he was taking, he was now experiencing some of the side effects with hyper-emesis from the marijuana. So it was now sort of a complex concoction of symptoms that he was now sort of presenting with. He did not report any frank hematuria. However, he was noted to have microscopic hematuria on the urine test. The other medications he was taking included metoclopramide as well as duloxetine. He denied taking any alcohol, but also occasionally took tobacco. He reported losing weight. He reported he was basically a slim person, but over this course of the year, he had lost about 10 kilos and was down to 45. His examination was otherwise unremarkable, except some tenderness in the left loin. His testes were normal size. There was no varicocele that was noted, and there was no evidence of ascites on examination. Urine microscopy, as highlighted earlier, picked up 11 red blood cells, but there was no growth in the urine that was picked up. His other blood workup was otherwise unremarkable with a normal LFT. Now the GP had organized a CT scan, and that initial CT scan, the report was noted that there was a query, potential Nutcracker syndrome, but they also noted that the spleen was borderline enlarged. There were varices that were noted in the upper abdomen, as well as, but the gonadal veins was not enlarged. Now this is just a video of the CT scan. I'll just scroll through. As you can note, there was an enlarged spleen, and you can sort of start to see some vessels coming up around the between the spleen and the kidney. And there you can see how compressed that left renal vein was. As you can see, the aorta, the SMA, and then very squashed renal vein, which was then also enlarged after that area. And I'll highlight here as well, this abnormal group of vessels that you can see in that corner there, as well as these vessels there around the kidney, which all these were large varices that were. So this presence of these varices added an additional 10 to the equation. Whether was there portal hypertension, was it just a Nutcracker syndrome? So that became one of the fact-finding missions to say whether was there portal hypertension as well that is causing this. He had been seen initially by the gastroenterology team, and this was to investigate these varices as well as to exclude other causes of abdominal pain. His endoscopy workup was all negative, and the H. pylori test also came out was negative. He then was referred to the vascular team, where he was extensively discussed in their MDT. And one of the things that they highlighted and mentioned was that in terms of his management, the options available would be a transposition of the left renal vein. However, there was potential challenge that the length would not be sufficient once you divide the left renal vein to the left of the SMA. That would not allow transposition. That's when the transplant team was involved. So he was then referred to the transplant team for consideration of auto-transplantation. A few months down the track, he was then seen in the outpatients in the transplant team. And this was a few months down the track. So the initial plan then was to repeat this imaging to see whether there was any change, because there was a bit of time between his referral and us getting to see him. But also there was the question of portal hypertension, and we sought to involve the hepatobiliary surgeons to see whether they could have any other thoughts with regards to this finding, and also to try and confirm the diagnosis with doing more targeted tests, the venogram and measurement of portal pressures. Now this is the repeat scan that we did, and as you can see there, that angle between the aorta and the SMA was only 20.5 degrees. By definition, if it's less than 41 degrees, then that's a potential, that's a Nutcracker syndrome. And it was also noted that the left renal vein was compressed by more than 80%, which in itself is another diagnostic criteria for. And in the report, they highlighted that there was formation of these perirenal vessels. He was eventually discussed in the hepatobiliary MDT, and given the information that they had at that time that there were no more LFTs, there was no evidence of ascites, and these endoscopies were normal, This was more of a typical abdominal pain with the presence of varices, but this was not enough to support portal hypertension. And at this point, with regards to the Nutcracker syndrome itself, the hepatobiliary team could not offer anything further, but they thought that there was no enough evidence to support portal hypertension given what we had. So the next option then was to try and have concrete evidence that there is a Nutcracker syndrome. So the interventional radiologist helped with venograms. And from that there, you can see there's wasting of the renal vein. This will be the region where the aorta and the SMA would be. It was a very tight narrowing that they had to use a special catheter that was ordered, the Simpson 2 catheter, which was a special catheter that they used to try to pass there, because all the other catheters would not traverse that narrowing. They, however, were not able to cannulate into the gonadal or the adrenal veins to try and see all those other collaterals. So from the images that they got, we were not able to fully show the presence of those varices that were noted earlier. They went on to do pressure gradient measurements. And of note here, as you can see in the right renal vein, the pressure was only 4. And then on the left, on the left renal vein, but to the right of the SMA, the pressure was 7. And to the left of the SMA, the pressure was 13. Now, this showed clearly that there was a difference in the gradient between these two veins of more than 5 millimeters. And for a diagnosis of Nutcracker, a difference more than 3 millimeters is required for you to be able to make that diagnosis of a Nutcracker syndrome. They also did portal pressure wedge, hepatic vein wedge pressures to rule out portal hypertension. And as you can see that both the central and the peripheral wedge pressures were all below 10. So this conclusively showed that there was no portal hypertension, but importantly, the diagnosis was now clear that this was clearly a Nutcracker syndrome, given the differences in the gradients between the veins and the evidence of compression on CT. The other baseline tests that were done were perfusion scan, which showed that there was almost equal function between the right and the left kidney. So this was a well-functioning kidney. So in summary, so we now had this young patient now who presenting with sort of atypical abdominal pain and 1 episode of hematuria, now with CT evidence of compression of the renal vein, as well as confirmation by pressure gradient measurement that there was a significant difference. And the diagnosis of Nutcracker here, I think conclusively had been made. However, the next step was what were the options in terms of managing. Now, the options that we laid on the table with the patient were the option of doing a renal vein stenting. However, this option was also as could be associated with issues of thrombosis or migration of the stent or erosion of the stent into the adjacent vessels. And given that tight angle of 20.5 degrees, there was also potential risk of that the stent might actually fail to work in that scenario. So renal vein stenting was an option that we at that point thought was not the best. Renal vein bypass was a consideration. However, he had these small, thin collaterals, and there was a risk that during that procedure, potentially he could hemorrhage a lot. Now, auto-transplantation, even with its inherent risks of transplant surgery and the risk of potentially losing the graft or even the risk of hemorrhage, we thought would offer him more of a longer term solution and a safe solution. However, with all these options, there was still no guarantee that this would resolve his pain. So after a long discussion with the patient, with these options, we did agree to trial conservative management. So he was referred to the chronic pain specialist, where he continued to optimize his analgesic medication. And also there was an option of regional anesthetic, which is one of the described method in management of this condition. However, because of delays in the system, the patient ended up not having this regional block. His BMI was quite low of 15.6. We'd given him a target of gaining at least about 10 kgs, and the dietitian helped on that front. So with the trial of conservative management, we waited and planned to review him in clinic. Now, this was now almost 1 year down since we had first encountered him. And still, he reported that there was no significant improvement, even with having gone through the chronic pain specialist that had not given him much relief. And he was now, now quite frustrated that there was seemingly no good solution for him. He had gained a reasonable amount of weight. At that time, he was now weighing about, now BMI had gone up to about 16.8, though he was still underweight. So he had made a decision that he would want to take a step further and go ahead with definitive intervention, which we had then offered a left nephrectomy with auto-transplantation. After a long discussion with him, going through all the potential complications with the risk of losing the graft, and that there was no guarantee that this would be the solution, the patient was still keen to proceed with an auto-transplantation. So we then proceeded with laparoscopic left nephrectomy. As you can see on this is the standard way that it's done locally here, the raw adlet with the 3 ports for laparoscopy. And in terms of the findings, you know that the spleen was enlarged. The anatomy of the graft was that of a single artery, single vein, and a single ureter. There were multiple collaterals, both on the upper pole, on the lateral aspect of the kidney, and the lower pole. And this took meticulous dissection and time using the ligature and ligaturing both sides of the varices and clipping in between to try and make sure that you do not have any extensive hemorrhage from these collaterals. After the specimen had been freed, it was then retrieved through this sort of groin incision, which had been pre-planned with the intention of using the same incision for the implantation. On the back bench, a lot of work was done to get the vessels and prepare the specimen for the implantation. An extraperitoneal approach was done, and an end-to-side anastomosis of the renal vein to the external iliac vein. And in this case, the internal iliac artery was used for anastomosis. There was a good perfusion. No stent was left in place in this procedure. This was his immediate post-op Mark III. As you can see that both kidneys are actually perfusing well, with the graft showing good perfusion with an HI index of 32.9. And also some evidence of some urine within the bladder at that point. So his immediate post-op was otherwise uneventful. You managed to discharge him on day 4. But what was of significance is that he did report that there was immediate resolution of his symptoms. The main pain that he was experiencing was pain from the surgery, but the initial symptom that he had completely resolved, which was quite an impressive outcome, given that he had had this pain for such a long time, and he could report that there was significant difference. We continued to follow him up, and other tests, the ultrasound scan, which was done at 1 year, was normal, as well as the creatinine on follow-up also was normal. We have followed him now for up to 2 years, and he has remained pain-free. Now, that was the case that we managed, which showed a good outcome with autotransplantation from a case that was quite difficult and atypical in its presentation. Now, Nutcracker syndrome in itself as an entity is still a case, it's still a condition which is not well described in terms of its management protocols. However, there's been an agreement that for mild cases, conservative management, which is either pain control and weight gain, these are the main parameters. And some patients do report improvement in symptoms just by with these parameters. Now, with the advent of the endovascular techniques, there is now a role for stenting, and some studies report up to 70 to 80% of improvement in the symptoms with stenting. However, stenting still remains the problem of the risk of thrombosis, as well as the risk of stent migration, which becomes can cause quite severe morbidity. Autotransplantation and renal vein bypass have been gaining sort of preference, especially in the management of severe cases. And these have shown good outcomes and more robust outcomes for the patients. I'll just dive into a few literature reports that I came across, so this is a this was a case series that was looking at the outcomes of renal vein stenting in Nutcracker syndrome, and different papers here were looked at. And I'll just highlight that in most of these papers, it was noted that patients reported that there was significant improvement. They all noted some significant improvement in their symptoms, and some had resolved up to about 72. In one series that showed up 72% report that their symptoms had resolved and improved. Also of note is that the patency rate of the stents reported that though some of them the follow-up was short, 1 month, there was 100% follow-up. In some of the cases, the patency was also quite high. After 3 years, still at 100%. So renal vein stenting is an option which has shown to have significant improvement in symptoms. However, of note, in some cases of reporting issues of stent migration, like in this series where there were 5 cases of stent migration, of which 2 of them had to be retrieved from the heart. So that is one of the major risks with renal vein stenting, with that associated morbidities. This here just shows this was a case report of a patient who had renal vein stenting for Nutcracker syndrome. And as you can see here, the stent had migrated and lodged in the heart. And this had to be retrieved by open heart surgery. So it is quite a significant risk which comes with the renal vein stenting, though its outcomes, though not quite comparable with surgery, they seem to be good. I'll highlight this paper as well, which was published just early this year. Now, this was a multi-center retrospective study, and these were patients who had presented with Nutcracker syndrome, which had been diagnosed either with venogram or the other tests which had, including CT scan, that had confirmed Nutcracker syndrome. And in some of these patients, some of them had had prior intervention, either by stenting or by bypass, but then had had recurrence of symptoms. Now, they looked at 105 patients who had autotransplantation either as a primary or as a salvage therapy. Of note is that in this study, 93% of the patients had durable and complete resolution of the flank pain, and this was reported up to 12 months. And also of note, there was significant drop in the usage of opioid analgesia, and you can see that in 46 from about 46% to 17%. This was demonstrable up to about 12 months. And even in patients who required opioid, there was still a big reduction in terms of their dosage requirements. So this shows that autotransplantation as a method of treatment for Nutcracker syndrome is actually a robust method, which in severe cases or other cases could be the ideal for management. So with Nutcracker syndrome, just in conclusion, it's again very difficult condition to diagnose, and it's remains in terms of its management to have proper set guidelines in terms of its management because of its high variability in terms of its presentation. There's still a lack of standardized guidelines in this. However, delayed diagnosis can lead to severe morbidity, which include even up to infertility and renal vein thrombosis. Its diagnosis, as highlighted in our case presented, is that it does require use of advanced imaging as well as pressure gradient measurement as a form of confirmation of the Nutcracker syndrome. The surgical intervention definitely has to be tailored to individual cases, and multidisciplinary input is required to be able to come to a good outcome for the patient. And successful resolution of symptoms is achievable through autotransplantation. These are just some of my references. Thank you.
Thank you, Matti. That was short and sweet, and sort of covered most of the discussion. I will now open the floor out for discussion. And if anybody wants to ask questions, please raise your hands, and I will ask them to. Is there? I'll just start off like this. Is there anybody who's logged in who has prior experience with Nutcracker?
Yeah, so we had managed one case in CMC Vellore. It was a 17-year-old boy who had presented with gross hematuria. That was his only presentation. And we had done all the imaging and did a cystoscopy. On scopy, we could find blood gushing out from the left ureteric orifice. He also had reported clots. And after ruling out all the causes of hematuria, then with ultrasound Doppler and CT angio and venogram, we came at a diagnosis of Nutcracker syndrome, and in him we had done a left laparoscopic nephrectomy, but did a auto transplantation on the right side, not on the left side.
So the main presentation was bleeding hematuria.
It was gross hematuria with clots.
Okay.
In a 17-year-old boy.
Okay. Andrew, you raised your hand.
Yeah, thanks. Yeah, I've had some experience with this over the last handful of years, and sort of fell in my bag of things I treat kind of by accident. And I mean, I think I've seen a handful. I'm a vascular surgeon and transplant. I've seen a handful of patients, young patients, through kids' hospital and young 20-year-olds, etc., that have had hematuria and pain, and it just generally settles down well. I saw a patient a bit like this that had been very extensively investigated, all other causes outruled, and had also had SMA syndrome and had a bypass of the duodenum as well. That's another thing that's a whole nother talk about when they have the combination. And I ended up doing an auto transplant on her, and she did extremely well. And since then, there is a support group through social media, etc. And I probably see a patient every couple of weeks now from all around the place, and I've done 13 auto transplants to this point. So it's
that's quite some experience there, Andrew.
yes.
In fact, ours is basically n equals 1, and we have some anecdotal references from the past from previous surgeons, and I don't think they have had any great relief with those symptoms. Just a follow-up question on that, Andrew. In your 13 patients, has any of the patients actually come back with pain, recurrent pain, and you had to do something different?
No, I mean, I'll give you a couple of perspectives, I guess, just from experience rather than any expertise in this condition. Diagnosis is certainly the hardest thing, to be comfortable that you've got a diagnosis. I get renal team involved, urology, do the MAG3 studies. Most of them get a ureteroscopy and some imaging to make sure. I mean, basically, you don't want to miss another pathology. The renal, I have steered clear of renal vein stenting. It's a large bore stent that's relatively short, so the risk of watermelon seeding it is, in my view, a bit too significant. And whilst they are easy to deploy, you need to remember this isn't a stenosis. This is a flattening of the vein. Okay, and one of the things, Mehdi, that in terms of imaging is intravascular ultrasound. So I've started using that as a routine. And one of the patients, the last patient that I did, actually had a true near occlusion of the vein. And when we ended up, and a lot of those collaterals around the kidney and the spleen, and when she had her nephrectomy, and I had consented her for nephrectomy or auto transplant, and I didn't know how much of the renal vein would be available to auto transplant. And I ended up doing a vein, a graft, an extension graft with a bovine pericardium to make a new bit of vein. And in the end, it didn't actually work very well. But that's the same problem with doing a vein transposition. I don't think it's ever long enough to just rotate down and sew it onto the IVC unless it's under tension, or unless you mobilize the whole kidney and let it come more medially. So if I decided to do that as a treatment, I think I'd be prepared either to have a bit of tension and put some sort of, angioplasty, a bit of Dacron or a bit of vein to widen it, or just put a whole tube of vein made with saphenous vein or something else just to get more length. You probably need a few extra centimeters. But I've not.
Thank you, Andrew. I will take Rachel. Rachel is our nephrologist. Rachel, please go ahead.
Yeah, thank you. I thought it was very interesting because I just had my first patient with Nutcracker syndrome most recently, and she was 20 years old. She actually presented first to urology with macrohematuria with a normal renal function, and renal was consulted to look for underlying causes of glomerular nephritis after bilateral ureteric stenting didn't yield any cause for the obstruction. There was no obstruction per se, but just macrohematuria. She required multiple transfusions, despite not having heavy menses at all, and just through just macrohematuria. We had an MDT meeting, and it was thought that she would benefit from a transposition of the left renal vein with stenting, but this was after multiple investigations, as Andrew alerted to, including the intravenous ultrasound, which didn't show much of a change in the flow until they dilated the renal vein slightly and saw that there was an improvement, and also to the ovarian vein as well. And we also had to do a kidney biopsy because, it was not sure what was the other cause for macrohematuria. So that's what happened. In terms of her pain, she still had left lung pain until the operation, but things have improved. Obviously, I'll be monitoring her because this happened quite recently, less than 3 months ago. So Santosh, you might be hearing from me if things are not going in the right direction.
Did you say she had a
that's interesting.
transposition and a stent?
Yes, so that's what the vascular surgeon decided to do at that time.
Rachel, that's very interesting. But the question that comes to my mind now is, Andrew, now this is a patient who obviously has a diseased kidney, isn't it? And she has glomerulonephritis.
No, she does not. She
does not have. So kidneys are normal.
Normal kidneys.
Okay.
Histopathology wanted to exclude that. So normal kidneys.
Okay. All right. Yeah. Okay. Dylan, you have a question.
Yeah, thanks, Santosh. Thanks, Maddie. The idea of renal vein stenting is interesting. And I think the obvious parallel would be with the treatment for May-Turner syndrome, where stenting can be used and has been used. But presumably these people, a lot of them are young, and with a venous stent in place, do they need to go into some kind of long-term, if not lifelong, antiplatelet or anticoagulation to prevent thrombosis within the stent, or is there enough endothelial integration at some point? And if they did have a stent and it was to have a complication, I know in some of those studies that you put up that in 3 patients in that first study, they did a sort of a salvage auto transplantation. Would it be possible to complete that laparoscopically, or does the presence of that venous stent make surgery, I presume, far more complicated? But then how would that change your surgical approach?
So from what I understand of these post-stented patients who undergo an auto transplant, what that particular group has advocated is basically going the open way, wherein you control the IVC and then yank the stent out and then do whatever you're required to do. But however, in this particular paper, Matty has presented today, it's basically 2 groups, University of Wisconsin and University of Colorado. Now, the 2 groups are totally different. University of Wisconsin's got the larger number of, I think around 70, 73, isn't it, Matty? And most of the cases were open surgeries. And the other group, Colorado, was mainly robotic surgery. What they had about 32. So it's 2 different groups. And the recommendation, what I understood was, they prefer the open technique. I mean, I'll put it like this. More common sense would tell me that if a patient has had prior interventions, it's easier to go open surgery, and then sort of provided the collaterals and all that have settled down. But then again, Nutcracker, the problem with Nutcracker syndrome or phenomenon or whatever you want to call it, the problem is there are multiple subsets of this so-called Nutcracker. Pain is probably one of the most debilitating issue associated with it. So, now with respect to the question of long-term anticoagulation, what do you think, Andrew? What are your thoughts?
I mean, I think antiplatelet therapy, I mean, the comparison with a May-Turner is somewhat apt, but remember, you've got a bone, a fixed bone, and a pulsating vessel squishing it. Here you've got 2 pulsating vessels. That's the difference. That's your watermelon seed. That's what would worry me more. You've got you've got active movement between the two forces, anterior and posterior, that would continually aim to push that out. Definitely, at least medium term, I don't think anticoagulation, just antiplatelet therapy, because it's obviously a low flow vessel. One last thing to add for another treatment regime that one of the patients actually talked to me about is something that is described as an external stent. Has anybody heard of that?
Yes, I've heard about it, but not really sure what it is.
Well, basically it's getting a bit of reinforced Gore-Tex, so a 10 millimeter Gore-Tex graft, and whether it's laparoscopic, robotically, or open, basically mobilizing that flattened left renal vein. And again, it has to be flattened, not stenosed, wrapping this around it and then suturing it and then attaching the edges of it to some surrounding, peritoneum or whatever, so that it won't move. And then it's an external force, because it's reinforced, you've got something then sitting between the artery and vein like that, so that it will no longer compress it.
Yeah, that's interesting.
Yeah.
Dr. Animesh, you have your hand up.
Yeah, hi. Thanks, Santosh. I just wanted to add, I think I haven't had any experience with auto transplanting, but funnily, I've done a few retrievals where the donors happen to have had renal vein stents for Nutcracker syndrome. And one of the things I think is that the renal vein stents, I don't think it's, you have to be careful when if you decide to put a renal vein stent in, because you might possibly burn the bridge of being able to auto transplant it later on. And also it may make the nephrectomy itself challenging, because the stent often goes a lot further into the renal vein than you realize, and also back into the cava. So I think, just the concept that open surgery is still a backup, it's not always the case in this sort of scenario. So you have to really think about all the options. And then if you're thinking about an auto transplant as a possibility in the future, I think you just have to be careful about putting a renal vein stent in this scenario. But certainly in my department, we've had a few patients who've had transpositions of the gonadal veins for a Nutcracker phenomenon. I haven't followed them up, and I don't know if they've had relief of the symptoms, but yeah, as a less invasive option to a nephrectomy and an auto transplant.
Yeah, thanks. Thank you, Animesh. I think it's a good thing that you brought this up, because in fact, that is probably one of the driving force to make my decision to go offer this guy an auto transplant rather than going the stent way. Because just in case if the stent doesn't work, then to go back to that area probably would be a challenge. So that's one of the things that drove me. Matti, just with that last paper, so one of the things that you mentioned was interventional, doing venography by interventional radiology would sort of confirm the diagnosis of Nutcracker. But in that paper, they also mentioned about something called the University of Wisconsin's loin pain hematuria syndrome, wherein they sort of would sedate that ureter. They inject local lidocaine, bupivacaine into the ureter, and then so this is under general anesthetic ureteroscopy, and then infiltrate that area with local anesthetic, and then see whether the patient is pain-free for the next 12 to 24 hours. And if that is conclusive, then they would definitely offer auto transplant. So both these groups actually did that. Any thoughts on that, Matti? Can't hear, Matti.
Oh, sorry, I was muted. Yeah. It's actually one of the tests that they used to distinguish whether a patient would eventually benefit from an auto transplant. So if that test was positive, then the chances that an auto transplant would succeed were higher, given that some of the other causes of pain, or could be just some neuropathy, some neuropathies of affecting the ureter or affecting that region. So this is a test that was used, and it showed that for all the patients that had a positive test, they then went on to do an auto transplant, and they ended up doing well. So it is a recognized test that they use to sort of try and tease out whether an auto transplant would work in the event of a Nutcracker syndrome. Yeah.
Yeah, thanks, Matty. I'm not sure any of the urologists in today has logged in. Andrew, among your patients, have you done any of this particular test for any of these patients? Probably not, yeah. But I suppose it's something it is, in fact, this particular paper for University of Wisconsin, a guy called, I think, Hans Solinger, it was actually published in 2018, and he described this test. I assume he's a urologist, so if anybody knows anything more about this test, any of the urologists. Rohit, have you heard anything of this? Rohit is a urologist who now works with us. He's just starting today. Rohit, any thoughts?
No, never heard of it.
Okay. All right. Anybody, any other questions?
Just another last comment, I guess. You know, we see a lot of patients with sort of pelvic pain, and they've been investigated and they're shown to have a nutcracker and a big dilated gonadal vein. And, you know, some of them have already been for gonadal vein coil embolization, some haven't. But that's one of the dilemmas I think I see, that when most of the pain appears more pelvic heaviness, sort of more the pelvic congestion type symptoms, that's one of the situations where considering a ovarian vein transposition may be in order. You know, that will basically divide and reduce the pressure into the ovarian, into the uterine varices. It'll help decompress the kidney, and then you don't have to touch the renal vein compression. Or I've warned a couple of patients that sort of have both, that, you know, proceed with the ovarian vein embolization, but be aware that may be your outflow of your renal vein pathology causing your pelvic symptoms, and by doing that you may develop loin pain or whatever. And I haven't seen any patients come back with loin pain afterwards.
And your patients, Andrew, was it all lap or open, or what was the method?
All lap. So I work with one urologist, Andrew Richards, that we've sort of, and one nephrologist. It's something we've sort of just developed on our own, sort of looking at what's been done elsewhere, and being able to offer transplant as well as transposition. You know, it's big surgery, it takes all day, as you know, but these are generally young, healthy people. You might find you see a few patients who've researched on the net that they actually go over to Germany, a place called Leipzig, where there's a physician there that spends a couple of hours with them and does lots of standing and lying and different positional ultrasound examinations, comes up with a big long report, and then sends a lot of patients off to his surgical colleagues over there. But a lot of them sort of come back, you know, with this big wad of paper, some of whom have bizarre symptoms. I mean, that's the problem. Once you start doing a few of these, you start to see all the nutters, so to speak.
Andrew, one last question for me. We're just running short of time. Is any of your patients, you actually had this issue of dilated splenic vein, and so, you know, that you had to rule out portal 1?
One patient. Most of them, the kidney looks macroscopically normal. There's not a lot of dilated veins. I mean, that's again the dilemma of there's not a good absolute diagnostic imaging test. It's just the supporting tests. So just the one lady, yeah.
Thank you. I'm just going to, Animesh, I thought I will just share this so that you can just update us on the coming conference. You want to say a few words, Animesh?
Yeah, thanks, Santosh. So the upcoming ASC conference, the transplant section's on the Tuesday. We've got a preliminary sort of agenda together, and we're sort of just confirming the chairs and the speakers. And I was actually going to reach out to you, Santosh, after this yourself and Bulang as sort of to ask formally for chairing a couple of the sections within the transplant day.
Sure.
The dinner was decided just sort of because of funding to be on the Sunday. However, we've probably got enough funding to also hold a second dinner on the Monday night, depending on interest and how many people are there. But I think because of the invited speakers and so forth, and the sort of difference in the way this conference is being funded this year, we've decided to combine it with the Upper GI team to have a nice dinner, basically. Otherwise, we were sort of didn't have choices of too many of the nice places around. But yeah, I think Susanna and I were going to touch base probably in a month or two, just to find interest, if people were still interested in having a dinner on Monday night as a side thing for transplant alone. And otherwise, it's a very interesting section, and we've got a lot of interesting speakers, and there's a strong focus on machine perfusion and normothermic regional perfusion, as well as the controversies around organ donation and definition of death and so forth. So it's hopefully very promising and exciting, and I hope everyone can join. But we'll send out the formal sort of flyers and the agenda when everything's formalized.
Thank you, and thank you, everyone. So it was quite an interesting webinar today, and just for everybody's knowledge that you all get a CPD point for this. And thank you, Caitlin, for helping out, and thanks, everyone. Good night.
Thank you.
Thanks.